Welcome everybody to the second session. So this is on hospital and outpatient practices, and I am absolutely thrilled to welcome three fantastic nurses who are leading the way in sustainable healthcare and planetary health across Europe. Firstly, I have David joining us. He's from Médecins Sans Frontières. He's been with Médecins Sans Frontières for over 14 years. As a nurse practitioner, experience in ICU and A&E, emergency and tropical health as well. He's had an interest in sustainability for around 10 years now, so brings a wealth of knowledge of how he's applied that to practice across disaster management, across working at Médecins Sans Frontières. So really pleased to hear from David shortly. We also have, in addition, we have Siobhan with us, Siobhan Parslow-Williams, who is an associate at the Centre for Sustainable Healthcare, is also a skills coach at the LDN Apprenticeship, the Sustainable Healthcare Academy, and also very proud to say a co-author on our book on sustainable nursing, which will be out later this year in September, which is published with Elsevier. So it's wonderful to welcome you as well. And then finally, we have Emma Pascali-Blakey, doctor, should I say? Apologies there, Emma. Emma has been a trusted colleague and friend for a number of years, huge amount of experience and a recognised national nurse leader in sustainability with phenomenal knowledge. Has been instrumental in addressing kind of system change in sustainability and planetary health. So really, really proud to welcome three very incredible people to the panel today. It's fair to say we're doing quite a lot within the UK, and there's a number of organisations that are embedding change. We've got the Royal College of Surgeons Green Theatre Checklist, which I'd urge you to have a look at. We've recently had the Royal College of Physicians have published the Sustainable Toolkit to integrate. That has a lot of pharmacy and diagnostic, but also a lot about clinics and outpatients, which I'd urge you to have a read and learn more about. At Great Ormond Street Hospital as well, they're doing the Born Green Generation, which is doing some phenomenal work. So a big shout out to Joe Freeman, who's leading that work. He's doing a lot of, the mission is to prevent over 1 million more bits of plastic going into the system, which is just amazing. And also the Royal College of Nursing is doing some great work. It'd be amiss of me not to, they're obviously leading on the Gloves Off campaign, but they're doing lots of initiatives as well. So just thought I'd mention that, just some further reading, some more learning for you to do. So without further ado, I'm going to hand across to David, who's going to share his insights. Thank you so much for joining us, David. It's a pleasure to have you this afternoon.
Yeah, here we go, David.
My pleasure to be here, and thanks for the introduction, Lucy. So my name is David, and I'm currently working for Doctor Without Borders, and I'm looking at our medical practice and try to see what are the opportunities to make it a bit more sustainable, hence producing a bit less waste when we provide medical care to our patients. And here I will show you a bit some of the initiatives that we've taken, some that we've implemented. And a key message that we try to pass on to our medical colleagues is that quality of care and sustainability go hand in hand. I will start by a very quick overview of what MSF is and where we work, and then I will share with you how we are engaging with our medical teams. So just to set the stage for everybody, MSF is a big NGO, international non-government organization, a medical one, working in 75 different countries. We've got around 50,000 staff and 10,000 beds, more or less. So it's the same size as the hospital network of Paris, for example, the APHP, or the Charité in Berlin, or the size of the Scotland healthcare system, for example. But we take care of very different kind of pathologies. We have hospital-based care and also ambulatory with a lot of consultation for malaria, HIV, or tuberculosis. I just mentioned 75 countries. We're actually working in the countries that are the most vulnerable to climate change, and hence it was very important for us as an organization to take a stand and to act on these issues. So after a lot of discussion internally, we finally integrated carbon reduction objective in our strategic planning. That was back in 2021. We have a roadmap towards 2030 with objective to reduce by 50% our footprint. Our footprint, it looks like what I would say a big international organization. So as a hospital, most of our footprint comes from what we buy, so procurements, but we have a big international activity. So transport is a bit bigger than a usual hospital, and then the energy. But Personally, as a healthcare worker, it's very difficult for me to see what is my role when I see this kind of figure. And so I want to dig a bit into more of what's happening in our healthcare system. I mentioned we have a roadmap. Medical practices are mentioned, but again, among these 6 main domains, most of them apply to a supply chain. We buy equipment from suppliers, we transport it, we store it in our facilities, in our pharmacies, and then we need to deal with the end-of-life management. However, that would not be very different from any company like a hotel or restaurant. But as nurses and midwives, we work in hospitals, and in hospitals, the context is very different. And there's a whole set of factors that influence the amount of resources we need to provide care to a patient. And that's what I want to dig into with you today. I'm going to use the work of Mr. Kaya. Mr. Kaya is a Japanese economist, and back in 1993, he made the link between the resources needed to grow an economy by a population and the pollution that was generated because of that. And we can use his work, his approach, to create links between all the resources we need for providing care to a patient and all of the patient that we care for. And to do that exercise, I start with all the resources we need to provide healthcare. We need to manufacture equipment, transport it, store it, and then deal with the end of life. And to do all of these processes, we need a lot of different resources. We use aluminum, steel, plastic, wood, but also fuel, electricity, and all of these activities generate waste, very different kind of waste. Gas, carbon dioxide, for example, but also wastewater, sometimes radioactive material. All of that, to make it a bit simpler, I'm going to call that the use of resources. And then I'm going into a bit the mathematical exercise of Mr. Kaya and saying that these resources equal to themselves. That's a tautology. It's a statement that is always true. And I'm going to multiply and divide by the same factor again and again. I multiply and divide by the medical equipment, the medical items that we need to provide care. I multiply and divide by the care we provide to a patient. And I multiply and divide by the patient we care for. It is a bit abstract, but doing so, we do identify 4 key factors, key parameters that directly influence our use of resources as a healthcare facility. We need the 4 key parameters is resource per item per care per patient, and number of patients we care for. Now that we know these 4 key parameters, we know what we can work on to reduce our use of resources. First of all, the impact per item. So for that, we need to work on manufacturing, transport, storage, and disposal. A very good example to illustrate that factor is reusable equipment, because less manufacturing, less transport, at the use level, we need a bit of water to clean them and much less waste. In MSF, we have a lot of examples. For example, the equipment we need for the surgical area. However, we are very conscious that we need laundry and sterilization when we want to use them. However, we are very conscious that reusable are less and less available on the market. Here you have a few examples of items that were reusable just a few years back and that are either impossible or very difficult to find on the market at the moment. It's just something to be conscious of. The second parameter is the number of items we need per act of care. To reduce this, we need to be efficient and responsible in our use of resources. For this, there's 5 key main levers to act. We need rational use, efficient forecasting to avoid wastage, efficient stock management to avoid shortages, efficient maintenance of our biomedical equipment, and to choose medical techniques that use less equipment. In MSF, to know exactly what to work on, we did an analysis and we looked at all the single-use medical items we use, and we've identified among all items we use in quantity, this one is in weight, that single-use gloves were by far the item that we were using in the most quantities. The personal protective equipment was the main big family in this analysis. The second big family was devices needed for injections, hence syringes, infusion sets, catheters, and needle. And this data is very congruent to the data shared by a European healthcare system. So it's very similar conception. Okay, now that we know that, what can we do? We can rationally use the gloves. it has been done and piloted many times in the UK and other places. We actually contacted the Gosh Hospital to look if it was possible to do the same in our context. We piloted and we reached very similar result with a 40% glove consumption reduction per consultation. So yeah, and many co-benefits linked to that reduction were an increased quality of care through a better hand hygiene practices, and so reduced healthcare associated infection. Another practice that we can encourage is to switch from IV treatment to peroral as soon as possible, as soon as it's clinically recommended for the patient. This is already not best practices, but this needs to be implemented. In order of magnitude, a pill is 10 times less carbon and 20 times less plastic waste and 40 times cheaper. It's really the big ballpark, but it varies from drug to drug. The third big parameter that we can work on is the number of acts of care that our patient need. And this will be directly proportional to the severity of the disease that we need to treat. And to be as effective as possible, it will then depend on how severe the patient is. So the most effective we are treating the disease, the less severe or the better the patient will be the fastest. And to do that, actually WHO, the World Health Organization, tells us that to be effective, we need quality healthcare. And quality of care is being safe, timely, evidence-based, equitable, and patient-centered. So we need to provide the right drug at the right dose, at the right time to the right patient. We need early diagnosis and treatment. We need treatments that implement the best practices, as the literature say. And then the last one, so the treatment needs to be appropriate, adapted, and acceptable by the patient. If it's not, the treatment will not be taken, and then the treatment needs to be repeated, and so we'll use more resources. In MSF, there is a lot of actionable things that we can do to operationalize patient safety. And we measure them, so we report healthcare related incidents. I'm sure you have systems to do that as well. We implement rational prescription, organize morbidity and mortality reviews, and implement a strong IPC policy and processes in our project. And just to illustrate, how can we provide timely care in our setting specifically? Well, in the context where we work, there is a lot of shortages of healthcare workers, specifically doctors. And so there's a lot of places where the nurses are at the bedside, but the doctor is not close by. So we actually, this is a training for nurses to help them recognize a patient that is deteriorating quickly, in a state of shock, respiratory distress, convulsion, loss of consciousness. Call for help, but maybe we need to wait 5 minutes for the doctor to arrive and take the first action in these first 5 minutes. So this is an example to illustrate how you can provide timely care. You can see that it's mostly for nurse and midwife in inpatient settings, and this is in context where we lack doctors. And so the last parameter we can work on is the disease incidence and how can we reduce the need for healthcare services, but for that we need prevention, health promotion, and disease management or patient education. A good example here is a patient with diabetes. If it's really well managed, he will not need the hospital. But if the glycemia is very variable, badly managed, it can lead to infection, neuropathy, amputation, and use a lot of resources down the line in the hospital, besides being really bad for the patient. To illustrate this example in MSF, how can we do health promotion? Well, facilitating breastfeeding. Breastfeeding is the single most effective measure for child health. So we do have tools to promote that in the context where we work. Another one is to, this one is more, also a prevention. A concept from the UK is to make every contact count. Every interaction with healthcare services is an opportunity to provide health promotion, health education, key messages. And in this case, we want to facilitate the evaluation of the vaccination status of under 5 children. And so we can catch up on the essential immunization program. So we see that we can work on 4 key parameters. we see that to have sustainable healthcare systems, we need to reduce the resource intensity of the equipment, have care efficiency and effectiveness, and to reduce the need of healthcare services. We've seen that there's key levers that we can use to reach these objectives. We need a sustainable supply chain. We need resource stewardship. We need quality of care through all of the dimensions from WHO. And we need to prevent the need of healthcare services through health promotion, disease prevention, and better disease management. So a sustainable healthcare system will be a combination of sustainable supply chain, resource stewardship, quality of care, and preventing the need of healthcare services. What's super interesting with this is that you see that all actors within the healthcare system have a role to play. Procurement, supply, waste management, nurses, doctors, everyone has a role to play in these 4 key factors. And so another key conclusion is also that quality of care is sustainability, and there will be no sustainable healthcare system without quality of care well implemented. And the very last thing I wanted to share is that when we ask the public who they genuinely trust to tell the truth, politicians score the lowest, nurses, midwife, healthcare worker score the highest. So what we say and what we do really matters. And I'll leave you with this consideration and pass the voice back to Lucy. Thank you.
Thank you, David. My name's Siobhan. Absolutely delighted to be here today. So this presentation I'm going to show now is about using sustainable quality improvement, which we call SUSQI, in clinical practice. And what I'd like to just show you first is a very simple illustration, just showing the importance of taking small steps. The SUSQI framework was coined initially by Dr. Francis Mortimer at the Centre for Sustainable Healthcare. And really it was designed to enable nurses, clinicians in healthcare to be able to break down problems into small, manageable projects and steps within our scope of practice, just to make these steps more attainable and realistic. And so as you can see, sort of illustrated in this picture, the smaller steps help us to get where we want to be, whereas when we make those goals too big, it can be a little bit overwhelming and more difficult to achieve. So SUSQI, we talk about putting knowledge into action. So I'm sure through this conference, you're going to hear, a lot about the issues that we're facing globally in terms of climate change and what that means for health. And that can be quite overwhelming. It can cause sometimes eco-distress. And the actual problem can feel so huge that we don't know where to start. And sometimes that eco-distress can cause a freeze response, so we don't feel we know what to do. But SUSQI helps us put knowledge into action. And when we're able to take small steps, that can actually relieve that distress and empower us, and together we can make a huge difference. So about the SUSQI framework, so we say quality is not enough. So David was talking about those domains of quality, but we also think we need to improve value and include sustainability, because if something is available today, we want to ensure that it's available for future generations. So this is the SUSQI equation. And so what we talk about is sustainable value equals, on the top, our main outcome is obviously to improve outcomes for patients and populations. That's the top line, that's our goal. But historically, quality improvement has usually just looked at financial impacts. So the difference with SUSQI is that it also incorporates the environmental impacts, so trying to reduce those environmental impacts of the healthcare that we deliver, and also increase social value in every opportunity that we have. And it's just worth saying that SUS-QI has been designed to embed into existing QI models, not as an alternative, because we think, all quality improvement projects should be sustainable. This slide just shows you what the principles of sustainable healthcare are. So first we have prevention, so we prevent health illnesses, disease, perhaps by vaccinations. David sort of spoke about the breastfeeding to save more babies. These preventative actions are really important. Then the second one is patient self-care, so empowering patients to take a greater role in managing their own health. Then the third one is lean service delivery, so streamlining care systems and minimizing wasteful activities. The fourth is low carbon alternatives. And the fifth, which is less clinical, but looking at sustainable operational resource use, so looking at efficient buildings, equipment, energy, water, and waste. When we're thinking about putting projects into place, this is quite a helpful tool to think about where we want to work in terms of where we want to do a project, because you'll notice that these are numbered 1 to 5, and there is a sort of an order of priority here. So obviously our number 1 priority is prevention, because the best healthcare is being healthy enough that you don't need any healthcare intervention at all. So it's quite a useful tool when deciding on what projects you want to do. So like I said, the SUS-QI framework is designed to be incorporated into existing quality improvement models. And so we do ask these top line questions when we're trying to undertake a project. So we want to know, what is it we're trying to accomplish? How do we know a change is an improvement? And what changes can we make that will result in an improvement? And then we have 4 very simple steps in SUS-QI. So the first step is setting a goal. What do we want to do? We're, thinking about what is the problem and where do we want to be? Then it's really thinking about studying the system. Step 2, thinking about what the system is currently like before we make any changes. Then the third step is design the improvement, and that's where those principles come in, and we can think about, can we design it around prevention, or the other ones are lean service pathway. And then the fourth step is measuring impact. So when we measure impact, we think about obviously the outcomes for populations and patients, but we're also thinking about that triple bottom line. So we're measuring the environmental impact, social impact, and the financial impact. So very quickly, I just want to show you a few projects that have used SUS-QI across the UK that have been implemented really successfully in the NHS over the last few years. This isn't, there's tons of projects that have been done, and I would recommend going to the CSH Centre for Sustainable Healthcare Networks website and looking on their resources. There's tons of projects that are on there, which you may get an idea which something that you could implement in your own practice. But just have a look at these. So this is a project that was done, I believe, in 2024. And they were looking at reusable tourniquets to make phlebotomy more sustainable. So the issue was there was a lot of single-use tourniquets being used, and actually staff said that they were harder to use, and patients complained that they were more painful because they kind of pinch the skin, and obviously a lot of waste was being accumulated. So the aim was to replace the single-use tourniquets with reusable ones in a cardio unit and renal outpatient department using this SUSQI framework. And the outcome was to use renewable tourniquets, and that was successfully implemented. And what they found is actually thinking about that equation again. So the top line, the clinical patient outcomes, is that they addressed staff concerns of patient harm. So, this quote here, trying to remove it while the needle was still in could cause trauma to the vein. It reduced variation in practice, and it was very beneficial for infection control and safety. And the patient said it was more comfortable as well, actually using the reusable tourniquets. The environmental impact was that they saved a whopping, well, if it was implemented trust-wide, it would have been 25,000 kilograms of CO2 equivalent in a year. They estimated if it was implemented trust-wide, it would be nearly £36,000 savings a year. And the social impact was that, the comments around patients saying that it was less painful and better for the planet, and what's not to like, really. So that was a really successful one and has been spread across the NHS as well. This second one was about kind of reducing unnecessary tests. So it's around reducing routine blood testing. So what they found was a lot of patients were having blood tests which were not necessarily needed, more a kind of just in case, or but they were low value and they weren't really adding to the value of the patient outcomes. So the team successfully reduced testing across 3 wards by nearly 10%. And what they found is that actually by reducing the amount of tests that they requested, they reduced the risks to the elderly patients, so they weren't bruising and risk damaging their skin. They reduced pain and distress, particularly in patients with cognitive impairment. And they also reduced discharge delays and improved patient flow, because if they were waiting on bloods to come back again, which weren't actually going to change, the outcome, it reduced those discharge delays. And also, I think it saved something around like 96 hours a week in the path labs. And then it saved 937 kilograms of CO2 equivalent a year from reduced consumables and blood processing, nearly £20,000 a year saving. And staff and patients agreed that, the excessive testing was a problem. Staff had more time to focus on patients. The lab staff saved a huge amount of time in processing, and less testing will likely improve patient satisfaction. And then the last one I'd like to just show you is a project that was done last year by the midwifery team at the North Norwich University Hospital in reducing the impact of nausea and vomiting in pregnancy. And they took an ambulatory approach and moved services into the outpatient on an outpatient basis. And they wanted to reduce the physiological, psychological and social impact of nausea and vomiting in pregnancy, and also the severe HG through a virtual telephone clinic. And this allowed them to give IV fluids and antiemetics at home or via the virtual hub. And they had a really good outcome. So women felt heard, received tailored treatment on their needs. They felt better supported, had appropriate follow-ups and optimized medication plans. And women with diabetes could continue their usual medication because they weren't obviously feeling unwell and vomiting and unable to take their medication. The environmental impact was equivalent to saving nearly just over 19,000 miles in an average car. Financial savings were around £750,000, which is huge. And the social impacts for the women, there was a lot of less disruption to their work, their family and daily activities. And, you can see by these quotes, my husband was able to go to work and my son had his mummy back. And it also increased staff confidence because they did do a training as part of their staff training, and it really increased morale, and they felt there was a huge difference they were able to make for their patients. So that's just a couple of projects that SUSQI has been implemented and been very successful in doing. If you're interested in doing your own SUSQI project, I'd just like to show you this website. There is a QR code on there, which should take you straight to it. And on this website, you'll find everything you need to know on how to set up your own SUSQI project. So there's a step-by-step guide. You've got all the resources and there's a lot of resources on there how to measure the carbon impact as well. So carbon footprinting. And I'd just like to say as well, the CSH have lots of awesome courses in SUSQI, carbon footprinting, etc. I'd just like to leave you on this quote from Greta, because she said, "I've learned you are never too small to make a difference." And I think, sometimes we can feel that our contribution isn't enough, but actually it really is. So I shall leave it there and hand over to Emma. Thank you.
Hello. Thank you so much, Siobhan. And what a wonderful sort of leader to end your sort of presentation on, because what we're going to start talking about now is leadership. And what I think we've heard over the past few minutes are incredible examples of nursing and midwifery leadership. And it's a real privilege to be here amongst such kind of wonderful colleagues who are doing so much leadership in your own spaces. And we know we've got global colleagues here doing that as well. So really, like I said, let's have a think about what we've heard and frame it around that leadership. So we know, as has already been mentioned, that nurses and midwives are some of the most trusted professions. And we know that in the UK, but it's translated, we've seen that represented globally as well. And we know that globally, healthcare produces around 5% of total carbon emissions. So this is actually a huge issue. And I'm going to talk to you a bit today about how I don't think this is necessarily a separate environmental issue, but actually this is an issue of quality, an issue of safety, patient safety, values. So actually this is fundamentally a nursing leadership issue, a professional issue. I would say that in the NHS there is recognition of that. The first health system to have these clear net zero ambitions. And we know that there are actions across the world that reflect that as well. So central to this leadership from nurses and midwives really, I think, is this idea of stewardship. And we're going to have a little look at that now. So I've drawn on some work by Dr. Yasai on planetary health and nursing leadership to sort of help frame this conversation. And the first dimension really of this planetary health nursing leadership is practical. So leading by example through everyday decisions. And David and Siobhan, you've illustrated that beautifully with lots of the examples that you've presented for us. It's thinking every single time we go and meet the communities and the patients that we serve, is this intervention necessary? Is it beneficial? Is it the right proportionate response to what we need to do? We also know that role modeling is really, really important. So as trusted professionals, we can support colleagues across the teams, so clinical teams, but also when we think about kind of communities and patients that we work with. And I think it's really important to remember here, this is not about being perfect. And I'm sure David and Siobhan, you'll have many, and Lucy as well, I can see you're nodding. There are many examples out there where we try something, doesn't quite go as expected, but with the main thing is, as Siobhan has shown us, we're taking that small step up the ladder, and it's so we really don't need to think about perfection here. And some of the studies that we've seen that are now published talk about the idea about honesty being really important, and imperfect choices help get people on side. People don't then feel intimidated and think, I've got to be perfect to make this work. Every single thing in my life has to be perfect for me to be a sustainable nurse, for example. And actually, like we've seen, it's that practical example, that practical implementation of this is reducing those unnecessary tests. It's switching to lower carbon products if we can, questioning, it's using our critical thinking and questioning. And we can use SUSQI to really embed that into our everyday practice. So it's not about less care, it's about high quality care. It's that fundamental nursing practice. So we can see that as that practical leadership and that stewardship in action. And like I said, we've seen some beautiful examples of that by Siobhan and David so far. The next component, I think, is really interesting. It's this idea of sort of ethical or moral, sort of values-based leadership. It's not just practical, is it? It's how and the kind of the values that underpin what we're doing. We know that in nursing and midwifery, there's lots of value-led work happening. A lot of the places that we work in, the organisations, our own profession is values-driven. And it's this idea that we want to support health in that wider sense of the definition, to support communities to feel, you know, supported and healthful, and that's something that we're looking at now for today, but we're also looking ahead to sort of future generations. And I think that's a really important thing to think about. So this is about going from purely short-term thinking, which is really important, and we do need that reactive work, but we also need that proactive looking ahead. So it's about making sure that whatever we do today doesn't compromise our ability to care in the future. That does require courage, that does require critical thinking, and asks us to go, why are we doing things in this way? So I think Siobhan, David, you've both shown us that you are those transformational leaders that go in, that use the critical thinking, that question, and you're also supporting colleagues to be able to do that as well. And I think that's really fascinating. And when we practice that and we use our critical thinking, I think we can start to think beyond wherever we're sitting in our professional roles. And then this sort of final piece, I think, is really important. And again, something we've seen very strong through the examples that David and Siobhan you've been talking about. It's not about having one answer that's going to solve everything, or there being one heroic leader that will solve everything. What we've seen here are teams coming together to make change happen, that collective, collaborative approach that I think as nurses, we do so well. We bring people together, as we are doing in the next few days with this amazing conference, but we're bringing people together, we're convening people, and we're building relationships and trust to make change happen. So it's not about one linear situation, it's a systems issue. And I'm sure all of us here are passionate about nature, as well as we are passionate about all this other work that we do. And we know that within nature, we see these networks, underground networks that connect trees and fungi to kind of do well and evolve. And I think that's where we can really use that as a way of illustrating how we can work well together. And I think it's a lovely illustration as well of that strategic thinking that as nurses we can bring to the table. So when we collaborate, across disciplines, across countries, we come together with engineers, pharmacists, doctors, scientists, carers, patients, the public, academics, can really start to think about what it means to bring that more prevention-focused work into play, that quality, and really supporting each other to make that change happen. Siobhan, you mentioned something again really important, which is about how we look after each other. So it's that approach we take to work is about supporting each other as well. And so for me, that leadership element here is very much about making sure we check in with each other, how the emotions connected to this work and how it can feel, and making sure that we're building networks and kind of cultures of care, so we can work together without burning out, without causing harm, and supporting each other through what can be quite challenging. I know I have definitely personally had wobbles. That's a bit of a euphemism for moments that feel quite tough in my mind. And I think that's where colleagues of mine I know who work in this space, we understand that we come together. So it's really about connection. And I think there's something really important here as well about diversity, about inclusion, and about making sure that whatever we do does not inadvertently cause more inequalities or more unequal sides to society. So we must always bring that at the forefront. And we can facilitate and convene as nurses for the benefit of the communities that we serve. So when thinking about sort of nursing leadership for planetary health, and when we think about what we can do in hospital settings, I think for me, it's very much about not trying to be perfect. It's about bringing us all together in a diverse group of colleagues with different backgrounds and different approaches, so we can really steward resources in all their definitions to really practically make that change. And I think that is nursing. It's always been nursing. And I'm really excited to have this next conversation with you all. Thank you.
Emma, thank you. Thank you, Emma. Now, I think we've got time. We've got about 15 minutes or so for us to have a bit of a group discussion and maybe some questions from the audience, if you're able to pop them in the chat. Oh, good, I see everybody now. Emma, Siobhan, David, thank you. I think you just brought together what nurses can achieve, and Emma, you've rightly said about coming together. That collective action and camaraderie and support is so critical. And I think that's kind of one of the big takeaways for me. I wondered if each of you could come to you each in turn for our audience and for those who are listening back to this. What would be I want 3 takeaways, so one from each of you. What would be your key takeaway for the audience today? Now, how could they start that over? I think we've all felt that overwhelming feeling of, oh my goodness me, we know there's an issue. What do we do? What would your advice be to the nursing and midwifery community on where to start? I might come to you first, David, if that's okay.
Sure. Actually, one that just thought about like 2 minutes ago, and it's Emma mentioning the connection with colleagues, because it's I wouldn't say a daily struggle, but that's true. Like, it's not every day easy. And I must say that connecting with colleagues with the same views and the same priorities was really helpful for me. And I'm glad to mention that in this space, because both Emma is running a community of practice among the NHS, and you at the CSH, Lucy, running as well for nurse and midwife. And I must say that this monthly space to share a bit and to learn a bit from like-minded nurses and midwife is of great support. And so I can reinforce this need for connection and sharing a bit the challenges. And this is the big takeaway from the past months, but also from today.
Thank you, David. So true, isn't it? That power of connection, and the networks are and free to access. So there's the Centre Sustainable Healthcare Network's a global network open to all nurses and midwives, and I know Emma chairs a network for nurses within the UK as well. So thank you. Very good point, isn't it? And actually, it's an opportunity to share, to celebrate, to, you know, offer support as well. It's great. Siobhan, I'm happy to come to you next. So what would your takeaway be for the audience today?
So I would probably say a little bit like what Emma was saying, it's not about perfection, you know, don't be afraid to start. You don't need to be a manager to be a leader. I think that's quite important. You know, you can be a leader in sustainability at whatever area you work in. It's progress, not perfection. Yeah, don't be afraid to start. And actually, you know, projects that may not work out that you know, as well as you thought they would are just as important as the ones that do, because then we can share that across the system and know, okay, well, we know that one, you know, how can we draw on that and we learn? And I guess the last thing is, you know, just connecting with David is finding like-minded people. You know, I think as nurses inherently we want to help people, and I think just talking about these normalizing sustainability as part of our role, and remembering that there's 29 million nurses worldwide, and you know we've all got a part to play, and together we can make, and I think we will make huge change.
Completely agree. Obviously, it's incredible, isn't it? The small changes, I think. But there's a lovely phrase there. What would you do if you know you would never fail? And it's it kind of opens up your perspective, doesn't it? It makes you think differently. Actually, the first step is often the hardest step, isn't it? And so true. Thank you, Siobhan. Always so inspiring. And then finally, Emma, what would your one key takeaway be for the audience today?
So I think it would be to use, I think what I think is one of the fundamental nursing sort of skills, which is that critical thinking and that questioning. And because I think what I'm hearing across a lot of the examples that we've shared, and I've heard many other examples, is it's always started with someone questioning, like, why are we actually doing this process in the way that we're doing it? And if the evidence is there, and if that's actually clinically the most appropriate thing to do, then absolutely this is what we need to do. But actually, how many things can we uncover through questioning? And then, as colleagues have already mentioned, that coming together, collaborating for change. And the other thing I would say is bring people in early and before any decisions have been made, and make sure there's that diverse group of people. And depending on where you work and what structures are like, you know, consider bringing in patients as well and communities to come to kind of work together on things, and framing things as that sort of joint challenge as opposed to a problem.
I like that. I really like that. It's interesting what you say about critical thinking. Is on Siobhan's presentation, she talked about the 5 areas of sustainable healthcare and clinical practice. And I always liken that critical thinking or evidence-based healthcare to the leaner pathways. It's about wasteful processes. And for me, that's always there's often so many times in your nursing practice, why am I doing this? This doesn't make any sense. And we don't often speak up. We think, oh, just go in your routine, drawing out your medications or whatever it might be. But actually it's being that boldness, isn't it? And saying, why are we doing it this way? Changing practice. That's what's kind of instilled in us, isn't it? Within our nurse education. So true and so valuable. And I love that framing of it's a challenge, all coming together to solve it, isn't it? Back to that camaraderie, isn't it? And working together. I think for me, I'm going to share mine. Mine's about, I think it's a gift, isn't it, to educate and share and raise awareness. And I found through my role at as head of sustainability that when I started in post, it was quite a new concept. And then actually, as you evolve and you get people involved, I guess to your point, Emma, is bringing people in early, is that, you know, it's our obligation, having that knowledge is about sharing it and empowering them to, or our colleagues or the public or whatever it might be, those around us, to influence them to make the right decisions as well. So I think for me, education and awareness is probably my key takeaway. And I haven't done this on purpose, I promise, but we have got, maybe I haven't done a bit of a segue, but we're very, very fortunate at the Centre for Sustainable Healthcare that we have been fully funded. So that's free courses for all nurses and midwives at all levels across the globe, so not just within the UK, all countries are open over the next year or so, for you to access, all online, for you to access. So I really would urge you, if you're joining us today and you want to learn more, we have a wealth of resources, case studies that you can use, share with your colleagues, educate your teams, and it's all free. It's all free for you to access. So a big thank you to the Burdett Trust for Nursing in the UK who have helped to fund that. And I'll share a link to that as well later. So have we got any questions from the audience at all? Any questions or comments that anyone would like to ask? No, I don't think so. I might come back to you because we're now at the end of our session. Just from all of you, I guess at the end of today's session and the conference and everything else, how are you all, how are you feeling kind of at the end of the session? And what are your final thoughts to share? Emma, I might come to you in reverse now. Over to you.
I think hopeful, and I know that sounds maybe like a bit of a, but yeah, I think whenever we can come together collectively like this, it does bring hope, because I feel I don't feel so alone, and I know that there is a huge community out there, which brings me a lot of hope and brings me energy, and I appreciate everyone for being here today.
Thank you for your time. Thanks so much for joining us. Siobhan.
Yeah, I guess, you know, that active hope as well, taking action and empowering, and hopeful that we're getting to that tipping point now where everyone is coming on board and we're gonna, you know, help get the world on the right trajectory. You know, it's quite ironic that as nurses and healers, we're in the position to be able to hopefully heal our environment, and you know, that's, I think, part of our role. So yeah, I'll leave on that.
Thank you, Siobhan. Well, and David.
I'm glad, because I feel there are more and more opportunities. This becomes a bit more mainstream and accepted, and this message that is a surprise a bit less. So I can see it internally. It gets accepted. The quality of care myth is deepened. So we start moving forward and getting a bit more accepted. So I think there's a bit of a momentum, and on a side note, I think we should do that more often. Hearing Emma saying so nice things about our work is really, really great. So I'll say yes to any other opportunities like that.
Thank you all three of you for your time and your wisdom and your insights this afternoon. It's been an absolute pleasure. I feel very fortunate to know you. That collective power and influence we have, we're using it for good, aren't we? Well, thank you to all of you that have joined us today. I hope you found it useful. We've shared a lot of resources and information that you can take away. And I guess, just to quote Siobhan again, is those small changes, that small steps will add up to a big impact. So keep going, take that first step. That's the hardest one to take. And as nurses and midwives, we have a huge obligation to lead this change. And I truly believe in my heart and my soul that we will lead the change we so desperately need to see in the world. But thank you for your time and enjoy the rest of your days.